Good afternoon, and thank you very much for coming. For those of you who haven't met me before, my name is Miriam Techmeyer. I'm leading the Community Health Systems Group in the Department for International Public Health. I'm really delighted to welcome Dr. Euphemia Sibanda today. Euphemia is an epidemiologist with over 10 years' experience of doing implementation research at improving the uptake of HIV services and interventions, right from testing all the way along to treatment and getting viral load undetectable. She works at the Centre for Sexual Health and HIV/AIDS Research in Zimbabwe with Frances Cowan, and some of you might have heard her talk in this very forum late last year. So, as an epidemiologist, you have a lot of skills, but you're also leading qualitative researchers, which is how we've met, because we've been working together on the Qualitative Research Network in the STAR consortium. And STAR is a big multi-country study scaling up millions of HIV self-tests in southern Africa. And so it's been really a privilege working together on that, investigating the impact of the self-testing scale-up. Today's seminar is entitled The Second and Third 90s, Where We Are, Challenges, Successes and Implications of Practice. So for the students, that's about the UNAIDS targets. 90% of people tested, 90 of those linked to antiretroviral therapy and 90% of those with undetectable viral load. And this is her first school-wide seminar. But we've been really lucky to combine this trip with her doing some lecturing on the master's module in HIV. So it's more than just a seminar. She's also been lecturing, and she's doing that in her role as an honorary research fellow here at LSTM. So welcome as an honorary research fellow. Welcome to your first seminar. Just a few lines about the lecture. It's very timely right now where we are with HIV epidemic control. And in fact, I would say, in theory, we know how to control the HIV epidemic. If we did what we needed to do, we could eradicate HIV in the next 5 or 10 years, actually, in theory. But human behavior is so much more complicated than that. And what happens at community level and inside people's decision-making processes and inside relationships and inside households is part of what has made us not reach to eradicate the HIV epidemic. And there's no magic bullet to this. You know, it's a matter of carefully combining different things, working out what works here and where. So we're really looking forward to hearing about that and about how things are working at community level in Zimbabwe. Welcome, Euphemia, and thank you.
Thank you very much, Miriam. And thank you, everyone, for coming to attend this session. It's very good to see all of you. So as Miriam said, I'm going to talk about how far we have gone and what our challenges and successes are regarding the first and second 90s. So I'll start by defining the 1990 targets and then go on to talk about our progress regarding achieving those targets. And as I discuss, I'll give examples from our work in Zimbabwe. So UNAIDS have set up fast-track targets that need to be achieved by 2020 and improved on by 2030. And just what are these targets? Miriam has already said to us that the target is by year 2020, we should have 90% of people living with HIV aware of their HIV status. And of those 90% of them should be on treatment, and of those on treatment, 90% of them should have viral suppression. What is really important for us to note is that across the cascade, what it really means is for the final 90, we are talking about 73% of people being virally suppressed when you're looking across the cascade. So really 73%, when you think about it, it's not too huge a target. And already, as we are at this stage, there's already been talk about how to get to the 10-10-10 that remain from the 90-90 targets. And modeling has shown that if we achieved these targets, we will be on track to eliminating AIDS by year 2030. An emphasis of these targets or of the UNAIDS guidance is the fact that we are looking at viral suppression more than we are looking at just numbers of people who are on treatment. And this is premised on the fact that we have evidence of the effectiveness of antiretroviral therapy, which has come from the landmark HPTN-052 trial, which found that antiretroviral therapy was associated with marked reduction in illness and death. And this was also confirmed by another trial that found similar findings. And you can see from that figure over there that with antiretroviral therapy modeling, we can expect that a person who is infected today and takes antiretroviral therapy effectively will expect to live as long as someone who is HIV negative. So this is really a good intervention that can have an impact on people's life expectancy. We have also shown from the HPTN-052 trial that antiretroviral therapy is associated with a marked reduction in transmission between discordant couples, where they found that there was a 96% reduction in transmission. And these findings, or this evidence, was also supported by a Cochrane review that was done afterwards, which included the trial, the HPTN-052 trial, together with 9 other observational studies, which all supported this evidence of effectiveness of ART in preventing transmission of HIV. So it's really important that we implement this intervention as well as possible. And to this end, WHO have issued treat all guidelines, which require that people who are HIV positive should be initiated or started on ART regardless of WHO stage of disease or CD4 cell count. So how far have we gone in terms of implementation of the treat all strategy? You can see from the map there that many countries have embraced these WHO guidelines, and we have a lot of them actually implementing treat all. And this is data as of July 2017. So where are we at in terms of the 90-90-90? We have these estimates that were done by UNAIDS in last year, and they were based on data that was recorded in 2016. And we can see that more than 2/3 of people globally are aware of their HIV status. So these are people living with HIV. And of those 2/3, 77% of them are on treatment, and of those, 82% are virally suppressed. So what you can see is our largest gap is on the testing, where we have 30% of people who do not know their HIV status, but we can see from the cascade that once someone knows their HIV status, they are more likely to be better engaged for the rest of the cascade. And one of the significant findings is the fact that for the first time, since we started scale up of treatment, we now have more than half of people living with HIV actually virally suppressed. But what we need to think about, especially related to this this first 90, is the fact that these estimates come from self-reports of HIV testing. And sometimes people do not feel able to admit to the fact that they are HIV positive. So it's likely that this 70% represents an underestimate of where we actually are in terms of the first 90. So this large progress in implementation of the first 90 is also associated with huge gains, where, for example, in 2010, there were 1.9 million new infections, which have now reduced to 1.7 million new infections in 2016. And it's largely because of scale-up of these fast-track activities, but also a combined effort with comprehensive approaches related to HIV prevention and better provision of services. But what's important to note is the fact that even when we are recording reductions in new infections in adults, we are going from 1.9 million to 1.7 million, and from 300,000 in children to 160,000. These numbers are still high. They are still alarmingly high. So what we need to do is to ensure that we keep doing as much as we can to scale up prevention efforts. And there are many activities that we already know can protect or can work in preventing HIV, and I will not go into detail in those in this lecture. So we've talked about where we are doing in terms of the 90-90, that we are at 70%, and we are doing okay in terms of the final 90, where we're saying in the third 90 we are at 82%. But really, let's think about what it means across the cascade. We can see that in terms of the testing gap, 30% of people don't know their HIV status. And by the time we come to treatment, yes, we have 53% who are already on treatment, but we also have a huge gap where we have 47% of people living with HIV who are not on treatment. And the gap further widens, where we have, in the end, 56% of people who are living with HIV who are not virally suppressed. And this is not good for their health, because it means they may delay in getting to treatment, and they may be more difficult to treat, wanting to go onto the more expensive second and third line regimens. And also the fact that they are not suppressed might also mean that they are likely to transmit HIV both vertically and sexually. So in terms of the gap, we still have a long way that we need to go. So what I wanted to say also is the fact that although in this lecture I'm talking a lot about the second and third 90s, it's really important for us to appreciate that the first 90 is really important for the second and third 90s. We cannot get to the third and to the last two 90s without effectively getting HIV testing levels up. And one other thing to note is the fact that we have delayed HIV testing that is happening. Even in the 2016 estimates that UNAIDS have reported, we find that almost a third of individuals are diagnosed when the CD4 cell count is well below 200. So we need to make sure that we do as much as possible to increase rates of testing. And one of the interventions that has been suggested for increasing HIV testing levels is HIV self-testing, which Miriam mentioned briefly at the beginning. We have the STAR project, which is a very large consortium of researchers working in 6 countries that has been responsible for scaling up HIV self-testing, and is producing a lot of information on what works and what doesn't in terms of increase of HIV self-testing and what can be done to support linkage of people who self-test across the whole cascade. Other interventions that work for HIV testing include assisted partner notification, point of care, early infant diagnosis, biological testing at birth for babies, and incentives for couples testing, which is an intervention that we have evaluated in Zimbabwe, and we found that offering small non-financial incentives for individuals who test together as a couple can result in a 13-fold increase in couples testing, which is associated with greater yields of HIV or greater identification of HIV infection. So I've given the global progress in terms of the 90-90-90 across regions, globally, but I also want to highlight the fact that there are marked differences by region, where we have some countries or continents which are doing well in terms of 90-90-90, but we have some which are really struggling. So it's really important for us to get to understand what are the things that those who are succeeding are doing well, so that those lessons learned can inform better scale up in the other areas. One of the huge gaps that we continue to talk about is that of the gender, where we see that the engagement of males is different, where if you look at the data from Zimbabwe, which is based on population-based surveys, you find that women are engaged better in the cascade, with 77% of them aware of their HIV status compared to 69% among the males. And we find that although progression across the cascade to the end is similar, we have that initial gap at the beginning, which is worrisome not only in Zimbabwe but also in other countries. For example, Malawi and Zambia, we see that there is less engagement of males in HIV services. There are many reasons why this is, which could include cultural norms of masculinity, where men perceive health services as female-oriented, and they might not like to access services as much as women do. But it's also because women, in many cases, have accessed HIV testing through ANC, because they are the ones who tend to go to the ANC clinics. So it's really important for us to find interventions for engaging men, and we'll talk about some of them in this session. We also worry about differences by age, where consistently in the last few years we've shown that young people are less engaged in HIV services. As you will see here, we have better coverage among the people aged 35 to 59, but when we come to this age group, the engagement is really poor, with less than 50% actually aware of their HIV status. And one of the biggest gaps that is also alarming is that of key populations, where you can see already in India, only 41% of people who inject drugs are aware of their HIV status, and we even have lower numbers for men having sex with men. So we really need to find ways and interventions of making sure that we engage everyone, so that no one is left behind. When we look at female sex workers, we have data that we have obtained from work that we are doing in Zimbabwe. One of the work we do at SESHA, where I work, is to implement a national sex worker program and do implementation and research among female sex workers. And what we found is that even among female sex workers, there is poorer engagement by age, where if you look at the young girls, they are not as well engaged as the older female sex workers, even in a setting like Zimbabwe, where a national program has been set up to address the needs of the female sex workers. And when we look at children, we can see that they are also left behind as a population. And this graph from the UNAIDS report is showing that we are not on course to achieve our treatment targets for the year 2018. And thinking about PMTCT, also related to children, you will see from this work that we are doing in Zimbabwe, SESHA Zimbabwe is the one that's responsible for evaluating the national PMTCT program. And here we're showing data from a serial cross-sectional study in which we had a survey in 2012 and another one, a follow-up survey in 2014, as a way of evaluating how well the PMTCT program was doing nationally. And you can see from this that women are doing okay in terms of their ANC and PMTCT cascade. But when you look at the next slide, where we are looking at the babies, the children born to the women, you see that they are not doing as well. They are not being engaged as well as they should be. And we actually have very few, if you look at the end, the infants who have received their results for EID are really suboptimal. And when you look at the PMTCT cascade, still this is data based on the national surveys that we are doing. We see that the women are doing okay in terms of the cascade as we know it. But what I would like us to discuss, as I said initially, when we talk about estimation of the first 90, there is a potential that we are underestimating the first 90 because of self-reports. What we have found in this study, where viral loads were also conducted in addition to self-reports, we found that there were a significant number of women, 29%, who were virally suppressed. They were HIV positive and were virally suppressed, but in their self-reports, they had indicated that they were HIV negative, or they did not know their HIV status. So now let's talk about those countries that have achieved the targets and see what we can learn from those success stories. Here is a list of countries where the 73% threshold, or the third 90, has been achieved. And one of them in sub-Saharan Africa is Botswana. And we can also have a discussion about how well or how they got there. So with Botswana, they have almost reached the 90% threshold. But if you get the first 90, that's what the first 90, and by the time you get to the third 90, they are well above the 73% threshold for the third 90. And what they have done is, to get to this point, is they have political leadership, which has been important in garnering support and services to ensure that there is good provision of services. And they've worked out effective ways of implementing HIV testing in such a way that they were able to have strategies that have increased yield or identification of HIV positive individuals. They also have decentralized care so that they can reach as many people as possible in their provision of services. And one of the things that is actually a challenge across many countries is the availability of viral load monitoring, which is important for monitoring individuals. And in many settings, this is not there, but Botswana have implemented this intervention, and it may have contributed to their success story. Another intervention or practice that has been suggested by WHO and has been ongoing in many programs is differentiated care, where we are saying the services that are provided should be client-centered. They should not be a one-size-fits-all provision of service. Health services need to make sure that when they think about when they are providing services to a client, where they are providing them, who is providing, all those things are centered to the client, and they make sure that they make the client better able to access those services. And we have seen that implementation of this client-centered approach enables better engagement in the HIV cascade. And in the next two slides, I'm going to talk about programs that have actually done as much as possible to ensure that they went out to provide services in a community-led approach to ensure better reach of services to the participants. The first one is the POP Art study, which is being conducted in South Africa and Zambia. But in this paper, they have reported their findings from the Zambia facility. In this program, they trained community health workers to go from door to door, offering HIV testing door to door, and then offering immediate referral, for immediate treatment to the local health facility so that people who were HIV positive could immediately access antiretroviral therapy. And what they have reported in their paper is a marked increase in both knowledge of HIV status and also initiation on art or treatment because of this intervention. Unfortunately, they've only done one round of this door-to-door intervention, which they do annually, and they have not yet obtained information on new infections and also on the third 90, that is on suppression of viral load. And an important finding from this study is that the cascade worked for both men and women. So this community woman-centered approach is something that can be used to reach men, because we've already said men are struggling in terms of the cascade, but going to them in their houses is something that can be useful in terms of identification. One challenge that they faced, though, is the fact that there was delayed linkage to the health facility, even among those people who had this facilitated approach, where they found that people took sometimes even up to a year before they linked to a health facility. And this is something that we need to think about when we are designing community-based testing programs, because there is that additional barrier for the person to leave their house and to then go on to health facility where they can be initiated on treatment. We also have another test and treat program. This one was done in East Africa. And in this one, they implemented a multi-disease testing program where it was not just HIV testing, but they also offered diabetes and blood pressure checks. And individuals got differentiated sort of care to make sure that they were assisted in linking to the health facility according to their needs. So they made sure that they did all they could to fight the barriers or eliminate the barriers to people linking to the health facilities. And those individuals that were not able to attend community-based campaigns that happened in the community were actually visited in their houses so that they could access the services. And this was found to be very effective, where at baseline, 44% of individuals had viral load, but this had increased to 80% by the end of 2 years of intervention, of implementation of the intervention. But what's also to note is that although there was increase among young people, the young people's data was not as good as the older generation, and this was because there was less adherence or less viral load suppression among the young people. And what the authors have reported on is because there was believed to be more stigma that the young people suffered, and they also struggled with logistics of doing prescription refills, especially where they were going to school or were in boarding school. Now I want to talk about a program that we are implementing in Zimbabwe that has been very successful in terms of supporting young people and could be useful in terms of making sure that they fight the stigma that we've just been talking about in the last slide. So there's this program, an organization called the Zwandiri program, which is run and supported by HIV positive peers who support the HIV positive young people, to tell them about HIV, to give them knowledge and support them in their adherence activities. And this has really been successful, and it's an organization that started in 2004 and has recently been awarded a large grant to scale up their activities across the country, because they've been seen to be a very good support system for young people living with HIV. And as SESHA, we are just starting a large trial where this same service that is provided by the Zwandiri is now being tried at facility level, where young people who are identified HIV positive at facilities can receive this additional support from the peers at facility level. And we want to see whether this is effective when you're comparing it with the normal Ministry of Health standard of care in terms of undetectable viral load. This is a protocol that has just been, the protocol has been published at trials, and implementation is ongoing. We have baseline results from this intervention, which the take-home message is that there is half of the children had virological failure. So it's really important as we think about how best to improve services for young people, to see what we can do to support them to be adherent to their medicines. Now let's talk about the female sex workers, what can be done and what has been worked in terms of programming for female sex workers. Again, I'm giving an example from the work that we are doing in Zimbabwe in a program that is the national sex worker program that SESHA, our organization, is running. It's a program that was established in 2009 and is nationwide, with 36 sites, which include 6 fixed sites and 36 mobile sites. And what happens is we have peer educators who support this program and help the programmers to provide clinic services and education to female sex workers so that they can reduce they can reduce their chances of getting HIV and also of transmitting HIV. The update is by September 2017, more than 57,000 women had visited the program, and more than 167 HIV visits had been made with a lot of HIV tests, as you can see there. And what we can see in terms of this program is that there is increased awareness of status, as we have, if we compare from the time the program started up to 2017, there is better awareness of HIV status, and also an increase, a decrease in treatment gaps, which is associated with the effectiveness of this peer-led provision of services that are client-centered for female sex workers. And thinking about their cascade, their engagement in care, the female sex workers in Zimbabwe, we found that there has been an improvement since 2013, where, for example, if you're looking, there's an improvement, a marked improvement in knowledge of HIV status, and a marked improvement in art and also in viral load suppression, although we are not yet reached the targets that we would want to reach for the female sex workers. So more needs to be done to ensure that there is engagement of the female sex workers, particularly the younger girls, because they are the ones who are less engaged. You may know from the WHO guidelines, one of now going on to other interventions that may be useful for the second and third 90s. The new WHO guidelines now specify the use of dolutegravir in the second and third, in the first and second line regimens, and this new drug is better able to achieve viral suppression faster and is likely to have less resistance and therefore cost less in terms of implementation. So its introduction of this drug is likely to make things better and to likely make programs improve in terms of achievement of the second and third 90s. I've already said before that viral load testing is something that we haven't been able to implement as well as we should across the cascade. According to the UNAIDS report, only half of patients had access to viral load testing in 2016. So this is something that really needs to be implemented more in order to ensure that there is timely, there is good monitoring for people and also timely decisions of whether to switch to second or third line therapies. We have a protocol that I found that has been submitted for an evaluation of whether point of care viral loads are going to improve outcomes, and that's something that we need to look forward to in the future. So in summary, as I conclude, really for us to reach the second and third 90s, we need the treat all approaches to be implemented across the globe. And although we have had a significant progress in achieving our targets towards 2020, we still have a huge gap. And we also now need to think about how to get to the remaining 10-10-10. Differentiated care is really important because we cannot get to our targets by just implementing a one-size-fits-all approach. We've talked about community-based programs being useful in making sure that we reach individuals that would not otherwise reach and fight some of the barriers to uptake of services. And peer-supported interventions have worked well among female sex workers as well as among young people, and it might be good to implement these to scale. And lastly, we need to improve access to viral load testing. Thank you for your attention.
Thank you very much, Euphemia. We've got about 20 minutes or so for some questions. Kindly wait until you get the microphone, so because it's being recorded, and that way we can capture the question and the answer on the recording. And if you could say your name as well, please.
Hi, Emily Adams. Fantastic presentation. What's the biggest threat to your programme?
Okay, so you mean the biggest threat to the achievement of the second and third 90s?
Yeah, is it funding? Is it Trump? Is it not engaging the youth? What is it?
I would say the biggest threat at the moment, we are at a point where we have done as much as possible to reach as many people as possible. And the biggest threat, in my view, is to have understanding of how to reach the the final gap of individuals. Because I think there is something unique and different about the people that have resisted these intensified efforts to reach them and to provide services. So we might maybe need additional strategies or need to understand better ways of making sure that we can reach them as well as we can. I think in terms of other resources, countries have, they might not have the necessary, they might not have reached their funding targets, but I don't think funding is the biggest hurdle at the moment because many systems have been set up to identify people, but there is that smaller percentage of individuals that we need to reach so that we are there.
Angela?
Hi, Angela Obasi. Thank you, Euphemia, for a really brilliant presentation that I think is of real interest to a lot of people, even people who are not able to come today. So is it possible to go back to one of those slides about the sex workers? Because Francis gave a presentation about the importance of sex workers as a group of people who are maintaining the program. So looking at that slide, in 2016, something happened. You know, you were able to achieve an upswing, an uptick in your outcomes. Can you say something about what happened there? Because whatever you did, it seems that we need to be doing more of it.
Okay, so I want to explain that there's been surges in terms of service provision, and one of the reasons made to understand that when you have these dips, it was because of differences in the funding or breaks in the funding, which would affect the way that the services are being produced and are being given, and also affect the numbers. So it's responsible for all these breaks. But when it comes to here, I would have to, I'm not really sure what could have been happening, but it's also at the same time that there was a trial of intensified service provision among female sex workers, which could have resulted in this huge gap, this huge increase.
And may I have one more question? Sure. So the other area of real interest is young people, because they have current problems, but they're also the receptacle of future problems. So what would be the most important thing that you think we should be doing to address, because it's all the 90s in young people, isn't it? So what are the key strategies that you think we need to be using in that group?
So for young people, I think the key strategy, in my view, is to make sure they feel comfortable about their HIV status. And there's Randiri group that I talked about, where there are peer educators who are also living with HIV. I think is a good intervention which can help young people see someone who is already doing well, and they can learn from that person to get to a point where they accept their HIV status and are better able to take to make decisions which optimize their care. Because what we've seen for young people is sometimes they just make a decision that I'm afraid of my friends seeing that I'm on care or I'm taking ARVs, and then they stop taking their drugs. Or sometimes they don't want the teacher or someone at school to know that they are taking their drugs. So putting in methods or interventions that ensure that they are well educated and informed and they are more comfortable about their HIV status will also be useful. And I think also one of the other challenges that we've seen even in the other East African studies is the fact that going to school also affects young people's ability to complete to do their prescription refills. So maybe making sure that the logistics of taking the medicines, prescription refills is something that is supportive or that is sensitive to young people going to schools. And yes, as we go forward, maybe less frequent dosing, I think, would also be useful for the young people.
Hi, I'm Lisa. And I was just wondering, so with the youth peer-led interventions, how do you choose who become the peers? Are they quite a bit older? Are they usually about 25, or is it a bit younger? Or
They are different ages. They are individuals who have been living with HIV for a long time, and they have gotten to that point where they are comfortable. They can share their story openly, and they are part of the support group. So when Zandiri started, it was sort of a support group of young people living with HIV, and it has grown from such a group. And I think the peer educators are selected from individuals who are attending the support groups, and they volunteer their services.
Sorry, since the microphone is next to me. I'm Chaba. I don't know anything about HIV testing, but the target, as I understand it, is 90% of people living with HIV should know their HIV status. I just wondered what difference is that going to make in that, when do people transmit infection? So if the peak of transmission occurs when they seroconvert and just after that, and you're testing sometime after that, how much of a difference is it going to make to get to 90? Isn't the key thing to test them early, around the time of seroconversion? I don't know how you would do that, but you're testing a lot later. And I see in your slides the rates of testing going up, but the actual outcome, the HIV incidence, doesn't seem to be coming down hugely.
Is that for these female sex workers?
Generally, I can't remember which slide it was, but even in the AIDS reports, the HIV incidence hasn't come down hugely. Small amounts over a long period of time. Often the comparisons are with one peak to where we are now.
Yes.
It's not such a big deal.
Yeah, certainly that's, I agree with you. It's an important point to raise, because even in the UN AIDS reports, they acknowledge that there's a lot of worry about delayed diagnosis of HIV. Showed somewhere that in the 2016 report, of the people that received HIV testing, almost a third of them did when it was really late. And there really needs to be interventions to make sure people are able to test as early as possible. And not just those interventions about testing, but we need to be doing more, and in terms of HIV prevention, stepping up our prevention efforts so that together with viral load suppression, we are able to achieve decreased incidence through a combination approach. I don't know if that answers your question.
Yeah, no, I think the problem is that the real period of transmission might be around the seroconversion.
That's true.
You're not catching that in the testing methods.
And also the type of
Yeah.
technology that
The
we
type
have
of-
available for
That's true.
diagnostics, it makes it very hard to diagnose acute HIV infection.
Yeah. Yeah.
The other thing that I'm very curious
Yes, that's really important to think about. Excuse me. It's really important to think about, especially when we are interpreting these 1990 data, because a lot of it is actually based on self-report. You're asking someone, what's your HIV status? And then you do your finger prick test, and you'll be able to collect your blood, and then you're able to determine whether they know their HIV status based on what they've told you. And I don't know if there's anything that we can do much beyond making sure that we implement methods of ensuring better reporting of better or more accurate self-reports. For example, at SEISHA, we use ACASI, audio computer assisted interviewing, where the individual has a tablet and they are listening to the question in private, and they should be able to report. But we still got that 29% of individuals that said they did not have HIV. So it's really problematic. I think it's really important for us, when we look at these estimates, to really think about the potential for error. But I think they're still very useful, because that's we don't have any other way of estimating.
Just two more questions. So Charlotte, and then here. Okay, 3. And then we're going to have to call a stop to it. Okay, Daniel, as you've got the microphone, and that is a powerful position to be in.
No, is that?
Charlotte also has a microphone.
Go ahead, mic off.
Thank you. So perhaps building up on from what Shaba was saying, have you found any interesting data related to the use of self-testing and reducing that delay in getting the diagnosis? So are you finding that people are finding out their status earlier than they would by having that resource and that test available?
Sure, yes, I didn't go into detail about self-testing, but definitely, yes, we found that HIV self-testing has increased the frequency of people testing, those who would not otherwise test. We found from the work we did in Zimbabwe that of all the people who received the self-test kits, 36% were testing for the first time. So we are actually identifying new people, new testers through the self-test intervention.
Yeah, I just want to understand this part. This door-to-door testing, how had the study evaluated that? Because going door-to-door, this is my first time of hearing of such information. I think you are pre-testing. What do the studies say about that?
Okay, so this I assume is the POP art study, which what they did is they trained community health workers who then went into households door to door, and they offered HIV services to individuals who were in those. They did a household enumeration, they offered HIV testing, and for individuals who were willing, they offered additional consent to have more additional data collected about them. And then if someone tested HIV positive, they got referral to immediately go to a health facility so that they could be started on immediate treatment. So this pop-art study, in this paper, they only reported on the intervention arm, or one intervention arm, which was one where they were testing immediate treatment of individuals that were identified to be HIV positive. So they had 3 arms, but the other arms were not reported in this. They were just trying to make sure that we got an appreciation of what was happening at baseline and after the intervention was carried out.
Here, and then Daniel.
Thank you. Toyin. So my first question is, I don't know why the male sex workers are excluded from, sorry I came a bit late, I don't know if you highlighted that, but from this program, why you excluded male sex workers in your HIV prevention? And then secondly, as at now, do you have any programs on ground that are capturing key population, like one-stop shops or anything that you have?
Yes, so in Zimbabwe, I just gave an example of the work that we are doing in Zimbabwe, and it's centered on female sex workers because that is the largest key population that we have in the country. And the services for the National Sex Worker Program, it's really a big program that is available nationwide, and their services to provide, the services have been set up to ensure that they can be provided with services both at the on-site clinics and in outreach. There are plans to find ways of engaging with the MSM community in Zimbabwe, but they are not as easy to reach as the female sex workers because of criminalizing laws in Zimbabwe. But there is an organization that we have started to engage with on how best we can provide services to the men, and this is something that we are just starting, and we haven't done a lot of groundwork, but definitely we want to engage them about offer of HIV self-testing services to gay men.
Hello.
Basically, Toyin asked my question because at the beginning of the presentation you did mention the gap on getting the men tested and getting the men included in this program. I was just wondering what has been your experiences toward the male population in Zimbabwe. I do remember you were in the presentations yesterday of the HIV clinic, and we mentioned about this community gathering of the male leaders to get them engaged in education and everything else. And the document that I read about it, it didn't actually talk about the results, but I would like to know about the experiences and the about trying to engage with the male population, and especially, of course, in male sex workers, which I imagine is also a key population. It must be.
Yeah. So in terms of engaging with the men in the general population, a lot has been done by the partner organizations with work with Ministry of Health, which includes mass media, is particularly challenging some of the cultural specific masculinity values to make sure that people understood. And they've been for ANC services which are frequented by women. There have been interventions to make sure that men feel better able to come to the clinics together with their wives. For example, if a woman comes to a clinic accompanied by her husband, then she goes to the head of the queue, that sort of thing. And those are some of the things that have helped the men to come along. But we still have a lot of barriers that we've encountered, including lack of time. The men give excuses that they're at work and they don't have as much time as women to attend health services. And the other bit about we don't have a big program, as I've just said, for the male sex workers, yes. Yeah.
Thank you so much. So allow me to thank Euphemia for her talk, and please do come and ask her questions briefly afterwards if you have them.